Welcome to our webinar, Navigating an Ever-Changing Pandemic. My name is Katie Ramos, and I am the Administrative Services Manager for Goodwin House at home. It is my pleasure to introduce your program moderator, Chief Strategy and Marketing Officer, Lindsay Hutter. Welcome, Lindsay.
Thank you so much, Katie, and welcome to all of you who are joining us today. I'd particularly like to welcome our Goodwin House at Home members, our Goodwin House Alexandria and Bailey's Crossroads residents, and the members of the Goodwin House Priority Club. I especially want to give a warm welcome to those of you who are attending your first Goodwin House event. Thank you and welcome. We are honored that you are joining us today, and we hope to see you at upcoming events, which we are hosting in person and virtually. For all of us at Goodwin House, the health, wellness, and safety of the older adults that we serve is our mission. And it is our mission not only professionally, but very personally. All of us have mothers, fathers, aunts, uncles, grandparents who are a part of our life. And you can see in this photo, my brother, my mother, and me. And for the last 2 years, my mother was a resident of Goodwin House, Alexandria. She passed away in December, and yet she's still present to me in so many ways. And just as my colleagues have the relationships with the older adults in their lives, we bring to heart all of those we serve. And at Goodwin House, you may hear the term family. Well, our residents, our members, our Priority Club members, our staff, we are family to one another. And so that also makes us passionate about the precautions during this pandemic that protect those we serve, as well as the freedoms which engage them in living. And that's a balance that we seek to strike every day, the protections and the freedoms. And so that's what today's webinar is about, helping us all gain clarity on the status of the pandemic and what, according to many experts, is a pandemic trending towards becoming an endemic. Trending towards, not quite yet there. Before we begin our presentation and discussions on this timely topic, I want to review a few housekeeping notes. Throughout this presentation, you will see PowerPoint slides and the presenter who is speaking on your screen. You may want to adjust the volume on your computer if you are having any difficulty hearing us. Also, everyone's microphones have been muted and your cameras have been turned off, as we are recording this presentation and want to minimize any background noise. At the end of the webinar, we will have about 20 minutes for questions and answers. And you may submit questions throughout the webinar by entering your question in the chat box, and it is on the right side of your computer screen. Simply click on the question mark, look for the chat box, type your question in the box, click send, and your question will be received by Katie. We ask that you indicate if your question is for a specific presenter or both. At the conclusion of today's webinar, we will invite you to complete a brief survey. Your feedback will help inform future webinar topics. As we have shared, we are recording the webinar, and we will send copies of this recording and the slides to you after the event. You are very welcome to share the recording with your family and friends. So here you have the agenda. This is how we're going to spend the next 60 minutes. I'm going to share just a brief overview of Goodwin House and the way that we serve older adults across the National Capital Region, and also give you some perspective on how we're navigating the current Omicron surge. We'll then move to Dr. Margaret Gloria. Dr. Gloria is the Goodwin House Hospice Medical Director, and she's going to give us the medical perspective from pandemic to endemic, understanding now where we are today and what we can expect next. And then finally, the best part, your questions and our opportunity to respond to those questions. So that's the agenda. And what I'd like to do now is give you just a little bit of a snapshot of Goodwin House. And this is all of Goodwin House. You may be familiar with Goodwin House at Home, one or both of our communities, our home health program. What I'd like you to do is just take a moment and look at this slide, because this shows you where we serve older adults across the entire National Capital Region. You'll see Virginia on the left side of your screen, Washington, D.C. in the center, and Maryland on the right side of the screen. And on the far right side of the screen is a legend, and it shows you on the top half the ways that we serve older adults, where they live, and on the bottom half, the health and wellness services that we bring to older adults, wherever they serve. We think this is a useful slide for people to realize just how many lives we touch across the National Capital Region through all of the services we have for older adults. And in fact, we touch 2,200 lives every day of older adults across the National Capital Region. Many people think of us as just in Virginia. We actually serve in the District of Columbia and in Maryland. And in a minute, I'm going to tell you about our brain health program and how we're touching the lives of older adults all across the country with that program. As we shift to the next slide, I want to get a little bit more specific about the ways we serve older adults where they live. And so if you see on the left-hand side of the screen, it lists the different places that older adults may live and the ways in which we serve them. So for those older adults who wish to age in their home, and the vast majority do, almost 80+% older adults say they would like to age in their home, we serve them through Goodwin House at Home, and this supports older adults 55 and better. We also have our two life communities, Goodwin House Alexandria and Goodwin House Bailey's Crossroads, which is in Falls Church in Fairfax County. That serves older adults 62 and better. And with those programs, Goodwin House at Home and our two communities, older adults can start at Goodwin House at Home, and if they later decide they'd like to move into one of our communities, we gladly welcome them in our communities, or they move into another senior living community of another organization if they wish. You might have heard about Avonlea, and Avonlea is a development in Chantilly in Loudoun County, and this is going to become the third Goodwin House community. It will be a rental community, and it will serve about 250 or 60 older adults. It is scheduled to open in 2025, and we're very excited about this opportunity to serve older adults in Loudoun. And then I also want to mention the Lewinsville Retirement Residence. This is a low-income housing community for older adults in McLean, Virginia, and Goodwin House has been very honored to be the managing agent for the Lewinsville for a number of years, and we serve about 130 plus older adults in Lewinsville. Now let's take a look at the health and wellness services that we provide older adults. On the left-hand side, you're going to see Goodwin House Rehabilitation and Home Health. These are rehab therapy services and home health services provided to older adults in our communities, but also in other senior living communities and in their homes across the region. We also have Goodwin House Hospice and Palliative Care, and our hospice service is extended to older adults all across Northern Virginia. So you see we serve older adults where they live, and we take all the services that we have to wherever they call home. Our next slide is going to capture our brain health program. And this is a newer part of the Goodwin House family of services, and its genesis is in the beautiful woman that you see on the right-hand side of your screen. That's Wendy Liebrich. Wendy is the mother of our CEO, Rob Liebrich. And when Mrs. Liebrich started to show some forgetfulness and some cognitive challenges, Rob sprung into gear to say, my goodness, I've had a whole career in senior living. How can I help my mother? And that became the genesis for something called Stronger Memory. Now, Goodwin House introduced Stronger Memory to our residents and our Goodwin House at Home members in 2019 and 2020, and the program has continued to grow. We have partnered with George Mason University on research to understand the ways that it is helping prevent cognitive decline. And what you see here on this screen is a quote from Goodwin House Alexandria resident, Dr. Robert Wallace. Dr. Wallace is the former chair of cardiothoracic surgery at the Mayo Clinic, and he is a participant in the Stronger Memory program. And here he's talking about how he's seen it help his cognitive retention. So learn more about Stronger Memory on our website and participate. We'd love to have you be part of this program. One last slide before we get to our featured speaker, Dr. Gloria. Many of you have asked, how is Goodwin House not navigating the Omicron surge? 3 words: conservatively, respectfully, and hopefully. And what do I mean by that? in terms of conservatively, we all know that Omicron spreads very, very rapidly. And when you serve among the most vulnerable people in our country, older adults, we're going to approach that very conservatively for their protection. We also have the protection of our staff members. Goodwin House employs nearly 1,000 staff to serve our members, to serve our residents, and to serve patients all across the Northern Virginia region. And so we need to be very conservative in preventing the spread across our staff so they can remain healthy and able to serve our residents. We're also responding to it respectfully. And what do I mean by that? Well, there is a balance of protection and freedom. And it's very, very important that older adults continue to be active and socially engaged and physically engaged and emotionally engaged. And so there is this balance that we're always striking with our precautions to protect and the freedoms that allow people to engage in other dimensions of wellness. We are also responding to it hopefully. You've seen in the news that we have that those who test positive, for many of them, it's more like a cold than it is a very serious respiratory shutdown. That's not the case for everyone. Our hearts go out to those folks that have tested positive and have had a challenge, or in some instances have died from COVID. But we remain hopeful about the trend line of Omicron not being as severe. I want to share one final thought before I introduce Dr. Gloria. And that is that as we study the temperature of the experts and the thinkers on COVID, we're seeing a shift. And this is this pandemic to endemic. And what we see in this shift is a movement from an isolation and prevention strategy to an accommodation and a mitigation strategy. And Dr. Gloria and I are going to talk more about that. She will in her presentation, and we will in the questions. And what does that mean for how we who serve older adults and older adults, what does it mean for how you think about your own life and the choices you make in this pandemic? It's now my pleasure to introduce Dr. Gloria. She is the medical director for Goodwin House Hospice. Since the pandemic began, I have had the pleasure of serving alongside Dr. Gloria on what we call the Infection Precaution and Planning Team. This is a team of senior Goodwin House leaders that has been in place for 2 years now, meets weekly. During the heart of the pandemic, we met daily to make determinations on what our protocols and our approaches would be. And Dr. Gloria has been a senior clinical medical voice to help inform the ways we protect our members, our residents, and our staff. You will find her to be smart, calm, and wise, and these are attributes that have definitely helped us these last 2 years. Dr. Gloria completed her fellowship training in hospice and palliative medicine, as well as internal medicine at George Washington University. She is board certified in internal medicine and hospice and palliative medicine by the American Board of Internal Medicine. Dr. Gloria proceeded a step beyond the ABIM certification to earn the HMCD certification so she could become a hospice medical director. Prior to joining Goodwin House, Dr. Gloria served on the inpatient palliative care team at George Washington University Hospital. Dr. Gloria, it is a pleasure to have you back speaking to us and informing us. Welcome.
Thank you so much, Lindsay, and welcome to everyone joining us again and to everyone joining us for the first time. I'm so glad that you could all be here with us. So I was thinking about this this morning. I think this is the 7th webinar that we've hosted now since the start of the pandemic, and it has really been a long 2 years. And that's an understatement. I'm going to leave it there, but it's an understatement. If we remember back to the last webinar, which was in the end of October, case numbers were trending down. We had gotten over the hump of Delta. Vaccines were rolling out for kids. Boosters were rolling out for adults. We were all looking forward to some kind of return to normalcy. We were talking about going from pandemic to endemic. I think we were very hopeful. We talked about predictions that case counts would continue to fall through the spring. And then bam, Omicron hit the scene in late November. And once again, we find ourselves in a whole new place in this pandemic. I'll tell you, I'm getting really tired of both using and hearing the term unprecedented. I don't want it to be unprecedented anymore. But here we are in the middle of a very different wave caused by a very different variant. So let's get into it. We're going to talk a little bit about what makes Omicron so different. And we're going to talk a little bit about the silver lining, because there always is a silver lining. So the story of how Omicron was first discovered in a lab in South Africa is actually very fascinating. If you haven't read about it already, I'll give you just the short spoiler. The lab was genotyping all of the samples that came in that were positive for COVID-19, and they started seeing that the genome that represented the spike protein, which is the little green knob that's sticking up off the top in that graphic, if you look at the graphic on the side of the slide there that represents what SARS-CoV-2, the virus that causes COVID-19, looks like. So they realized that the whole genome for that spike protein was missing altogether. And they thought, that's really odd. Maybe it's a fluke, maybe there's something wrong with the machine. And then they kept running these samples and they kept seeing that that genome, that part of the genome was just missing. So it turns out they realized they had a problem. They regenotyped the whole thing and realized we had a new variant that had more than 30 different mutations in just that one part of the genome, making the spike protein look so different that it wasn't even getting picked up on by the previous tests. So really kind of a fascinating thing. So what we know about Omicron so far, it is much more contagious than the previous variants that we've seen. There's a shorter incubation period, which actually helps aid in why it's so contagious. For Delta variant, for example, the incubation period, so the time between when you were exposed and when you developed symptoms was averaging about 5 days. There's of course a range, but we'll talk about averages. For Omicron, we're seeing more like 3 days for the average incubation period. So that in and of itself helps a virus be more contagious, because it makes it harder to go back and get the contact tracing done, because you only have 3 days before people are developing symptoms and therefore symptomatic and contagious to others. We're seeing that Omicron appears to be more mild than the previous variants, which is a good thing. Part of the reason that we think it might be more mild is because it tends to like the upper airways more so than the lower airways. So when I say upper airways, I mean basically everything from the collarbone up. And when I talk about lower airways, I'm really talking about the lungs. So if you can imagine, if a virus gets down into your lungs and causes that organ to fail, that's when patients really run into trouble, right? Because they can't get oxygen into their blood to oxygenate all of their vital organs. So there have been some studies done, there have been some anecdotal case reports and some evidence, but there have been a couple of articles. I read one recently in the Wall Street Journal that talked about how they grew human tissue cultures in the lab of the various types of tissue from the upper and lower airways. And they could see just in that Omicron really preferred to be in the upper airways versus the lower airways. So the two things of having a shorter incubation period and being much more contagious, by the way, that's probably part of the reason it's so contagious, is because it's concentrated in the upper airways. So every single time you breathe out, there's a lot of viral particles that are getting into the air. So the combination of the shorter incubation period and being more contagious makes this spread like wildfire. And we're going to see that on the next graph. So we've looked at this graph many times before. This is taken from the New York Times. It's just a graphical representation of the number of new cases that are reported every day in the United States as a whole. And the line, the dark red line that you see, is the average for the rolling 7 days right behind that particular date. And the reason that we do that is because there's always a little bit of variation. So there could be, and for example, and I'll get to this in a second, there were over 1 million cases reported on January 10th, but then the following day there were only 700,000 cases reported. So we use the rolling average to give us a better idea of where we really are. So when you look at this graph, that first big spike is that winter spike of 2020. We talked a little bit, or I talked a little bit when I first started about how different things are now. So remember back to winter of 2020, we did not have vaccines yet. It was a very scary time. A lot of people were sick. A lot of people were getting very sick, and a lot of people were dying from COVID-19. Then we had the Delta wave, which is that second wave that you can see just before October on the graph. And we had vaccines by that point. It was a little different than the winter of 2020, and it just didn't feel like it was so bad. Now look at that third spike. That's Omicron. That is unbelievable, right? Look at how different that spike looks compared to the previous two. It is so much larger and the curve is so much steeper. So if you think back to the winter of 2020, we were averaging about 250,000 new cases reported in the United States every single day. Right now with Omicron, the rolling average is 780,000 cases every day. And like I said, on the 10th, we had almost 1.5 million cases reported in just one day. So it's hard to say because it's early and things could change. And like I said, from day to day, there are certainly variations in the number of cases that are reported, and that's very normal. But I will say that since the 10th, the 11th, and the 12th, the cases have been lower. And in some of the metropolitan areas, they're starting to report lower case numbers. So I'm hoping that it means that the curve is starting to level out already. The good news is that the peaks usually look pretty symmetrical. So if it went up as fast as it did, it's likely to go back down at least similarly, if not equally as fast. Some even hypothesize that Omicron, and this is part of the silver lining, might be a blessing in disguise because people are far more likely to recover from Omicron and then therefore be immune. And so it may be that so many people are getting sick and it might add a little bit to the number of people that we have in the community that are immune, because that's really what is important, is our herd immunity, right? But the number of new cases every day isn't the only important data point that we should look at. We should be looking at others, and I'll tell you why on the next slide. So again, I'm going to go back to, remember, this is a very different place. So I talked about Omicron is so different. We have vaccines and we have treatments now. So imagine in your mind if 1 million people contracted the common cold. Would we care? Probably not, right? Because we know that there aren't really going to be repercussions for people having the common cold, maybe a couple of days missed at work, what have you. But if 1 million people contracted COVID-19 as we know it now, we'd care a lot, as we do right now with this surge. And that's because when people get very sick, there's significant impacts on our daily lives. And so that affects the supply chain, it strains the hospital systems, people are missing work. You know, you're reading articles about these snowstorms are coming and there's areas where they don't have enough people to even operate the plows. And so that there's a snowball effect, right? So if you look at the number of hospitalizations and deaths and you put it into perspective, we are not looking at anything nearly as severe as what we were looking at during the winter surge of 2020. And so I'll show you that. So if you look at the first graph, that's the number of hospitalizations every day in the United States. We actually did recently just hit about the same number of hospitalizations as we were seeing back in 2020, in winter of 2020. But if you think about it, think back to the graph we just looked at, 3 times as many people are sick, right? So the fact that we have about the equal number of hospitalizations is a good sign. Let me just give you a caveat. The hospitalizations and deaths always lag by 2 to 3 weeks. And that makes sense when you think about it, because first you have to be diagnosed with COVID-19, which again was the slide we just looked at with the red graph. Then it takes a little bit of time to get sick, to need to be hospitalized, and if is the case, to succumb to COVID-19. So when we talk about these numbers, please know that these will change over the next coming weeks. And it's very possible, in fact, I expect they're going to get worse. I hope they're going to get not too much worse. That's definitely the hope. So if you look at the graph on the right-hand side, that's the number of deaths reported every day. So when we were at the peak in winter of 2020, we were reporting more than 3,000 deaths every day in the United States due to COVID-19. Right now, we're floating at about 1,500. So half as many deaths, considering we have 3 times as many people every day that are being diagnosed with COVID-19. Again, all things considered, I think that we're faring pretty well. When you think about the people who are really sick, the people that are hospitalized, the vast majority tend to be people that are immunocompromised or unvaccinated. And in large part, the numbers of people being hospitalized are being driven by people under the age of 60, actually, which is interesting. If you compare people who are over the age of 65 and how often they're getting hospitalized to last winter, fewer people over the age of 65 are getting hospitalized right now as compared to last winter. And again, I think that just reflects that more people over the age of 65 are fully vaccinated. But these are the numbers that we want to watch. Again, if it's a common cold, it's really not such a big deal. If it's COVID-19 as we know it, it's going to be much more concerning, but only time is going to tell how well we fare with this, okay? So we touched on the concept of what happens around the world affects us here at home last time, and I think given the changes since our last webinar, that statement couldn't be more true, because here we are in the middle of this Omicron wave. So this is the same graphic, also from the New York Times, that represents the number of cases reported every day worldwide. You can see that that spike for Omicron looks very similar to the way that it looks in the US. This is bad because in general, when we have a lot of spread, it means, you know, every time the virus jumps from one person to another, or even from one species to another, that's another chance for it to mutate and make new variants. So what happens around the world affects us here for sure, and that's what makes vaccines so important. So let's look at the vaccines around the world on the next slide. This is a graphic, again, from the New York Times. I just find their graphics to be a little bit easier to read. I like the color scheme that they go with, but this information is available from the CDC, the WHO, lots of other organizations. So this is a color-coded map of the world that represents vaccination rates by country. So the countries that have vaccination rates where more than 80% of the population has received at least one dose are that darkest green color. And then you can see there's a whole spectrum to the lightest green color, which represents countries that have less than 20% of the population that have received just one dose of one of the COVID-19 vaccines. In some of these countries that are the lightest green color that you can see, less than 5% of the population has received even one dose of a COVID-19 vaccine. So you can see that we have a long way to go. Worldwide, 61% of the global population has received at least one dose of the COVID-19 vaccines. Now remember, for herd immunity, we were hoping to have at least 70% of the population vaccinated. And when we talk about that, we mean fully vaccinated. So we have a long way to go. Let's talk a little bit about vaccination rates in the US and then locally here. So the table on the left, it shows the vaccination rates countrywide. So across the entire United States, and actually this has been updated just a little bit. We have to always put these slides together for you a couple of days before we present. I think now it's actually 75% of people all ages across the United States have received at least one vaccine, and 63% are fully vaccinated. 95% of people who are over the age of 65 have received at least one vaccine, and 88% are fully vaccinated. That's wonderful. That makes me so happy, because that's, of course, the population that we worry about, people that are at the highest risk. So one thing to remember, this graphic does not include boosters. They are talking solely about if you got your first and second vaccine of the mRNA series, or you got your one dose of the Johnson & Johnson vaccine. So boosters not included. I feel like in general, we just need to get everybody vaccinated in the first place, and then we can focus more on our rates of boostering. I will say that the rate of people getting boosted is much, much lower, particularly for people that are younger, than the actual rate of vaccination that we're seeing. So the graphic on the right-hand side is a map of our area, the Washington, D.C., Maryland, Virginia area. I always find us based on the Chesapeake Bay, right? So in Fairfax County, you can see that the dark green color is kind of concentrated around DC and where we are. So I can tell you a little bit more specifically. In Fairfax County, 75% of all people who are eligible for a vaccine are vaccinated, and 85% of people who are 65 and older are fully vaccinated. So that's on par with the national average. Arlington and Alexandria are close, but they're a little lower. In Arlington County, 71% of people that are eligible are fully vaccinated, and 78% of people who are over the age of 65 are vaccinated. In Alexandria, 59% are fully vaccinated, and 76% of people over the age of 65 are fully vaccinated. Still makes me feel really good when I look at that, because in our general local area, enough people that are over the age of 65 are vaccinated, and so that makes me feel pretty good. So when the Delta variant swept across the country, it was evident that the vaccines worked, both to keep you from contracting COVID-19 in the first place, and then also to keep you from getting very sick and dying from it. With Omicron, vaccines are still working. They may not protect you from getting Omicron. And if you think about it, that goes back to all of those mutations in the spike protein that we talked about. That spike protein just so happens to be the exact place that the mRNA vaccines target. So of course, they're having a little bit of trouble keeping up with people not getting infections in the first place, but they certainly are still working to make it so that people don't get severely ill from this Omicron variant. We're hearing from doctors that are in the hospitals running the ICUs and the wards that the vast majority of people who are in the ICU on the ventilators are, again, unvaccinated or severely immunocompromised. So it's likely that people that are immunocompromised are going to be eligible to receive a fourth vaccine very soon, or a second booster, same thing, just depending on how you describe it. The CDC, the FDA had talked maybe in October about making another booster available to that group. At that time, they had said they would probably look at a 6-month timeline. And since Omicron, now they've decided to probably move that back to a 5-month timeline. So those boosters were first available, I want to say in September-ish, if I'm remembering correctly. So that means that people who are severely immunocompromised, we should expect we're going to be hearing about another booster for them coming up within the next month or so. Israel is already offering a fourth vaccine for people who are immunocompromised and for anybody who's over the age of 60. So they've always been ahead of the curve as far as vaccines. So I think everybody's just watching very carefully and hoping to gain some knowledge from that data coming out of Israel about how helpful a fourth vaccine is for people over the age of 60 or 65, and then of course extrapolating that out for the general population. The take-home point is that we are all going to need boosters at some point. It's just like a flu vaccine, just like the flu virus changes a little bit every season and we have to get revaccinated every fall. We should expect the same for COVID-19. The question remains, how often are we going to need to get vaccinated? My sincere hope is that it is every year, and not any more often than that. So I wanted to talk a little bit lastly about treatments. So remember, remdesivir remains the only FDA-approved treatment for COVID-19, at least full FDA approval. Everything else that I'm going to talk about today on this slide has received emergency use authorization at some point, so meaning that the FDA has enough data to say that they think that the treatment is helpful and not dangerous to go ahead and authorize it, given that they feel that these are emergency circumstances and that the treatments are needed. So the first one, oh, wait, let's take a detour really quick and go to medical school. All right, just for a moment. So here's a trick to identifying treatments and medications. A lot of times you can tell by the way that the word ends. So molnupiravir, you can see it ends in VIR, so VIR for virus. Every drug that ends in that VIR is an antiviral drug. So molnupiravir, antiviral drug. Monoclonal antibodies end in MAB, M-A-B, so monoclonal antibody, M-A-B. So you can see the under that category, those drugs end in MAB. And then drugs that end in NIB, N as in Nancy, I, B as in boy, are drugs that block a particular pathway. So kind of just keep that in mind. If you see these drugs around and you can't remember what they do, it depends on what they end in, okay? All right, so getting back to it. So molnupiravir, we talked about during the last session, it's made by Merck. When Merck initially presented molnupiravir to the FDA, they had some limited studies that showed that giving molnupiravir to people who had mild to moderate COVID, who were at high risk for developing serious COVID, could reduce their risk of getting seriously ill by 50%, which is huge. And we talked about how huge that was. They had actually cut that trial short because that's the standard. If you have a clinical trial where you're seeing really obvious results, it's ethically expected of you that you cut the trial short, because if you continue to go with a blinded trial, you have half the people in that trial are not receiving treatment that's really, really helpful, or really, really not helpful, depending on how it's going. So as is the standard, they cut that trial short because their data looked so good they realized they needed to unblind it and give it to everyone who was in the trial. So as time went on, though, and as after molnupiravir received emergency use authorization and it started to be used in clinical practice, we started to see that the participants in that original trial, and again, people out in the community, the benefit was really actually closer to 30% risk reduction of developing serious side effects of COVID-19 or dying from it. So that's much reduced. There's another little wrench in all of this, and that is that there have been some serious concerns about the way that molnupiravir works. So it works by scrambling the genome of the virus so much that it results in catastrophic mutations that make the virus unable, to continue to replicate itself. So some experts are voicing concerns. Why would we introduce a drug that can cause more mutations to a virus that's already proven that it can mutate like no one's business? And so a lot of people are saying for the minimal benefit, I don't know that the risk is worth it. So I think that we'll be hearing more about molnupiravir in the future. I think for those of us that might prescribe, it certainly gives us some hesitancy, and maybe in the future the FDA would remove their emergency use authorization, but we'll have to see. So there's another new medicine on the scene, similar, another antiviral. It's a combination of two. It's made by Pfizer. So it's nirmatrelvir and ritonavir. So both have been around for a while. This combination was initially studied in the early 2000s against SARS, which, if you remember, is the original. So the virus that causes COVID-19 is SARS-CoV-2. SARS is caused by SARS-CoV-1. So related. So they realized, hey, we could use this medicine that we developed for SARS to maybe try and treat SARS-CoV-2. It used to be an injection, but they've reconfigured it now to be a pill, so an oral tablet that you can take. And in studies early by the manufacturer, caveat that, it's shown to reduce the risk of hospitalization and death by 88% in people that take it, that again have mild to moderate COVID that are at risk for developing serious COVID. It works very similar to Tamiflu. So for the flu, we use Tamiflu for the same purpose. It needs to be given within the first 5 days of symptom onset, otherwise it's not as helpful. And so far, we're seeing that in preliminary tests, it is very helpful against Omicron specifically, because it can target a specific protein found in the Omicron mutation. So it looks like it's going to be a key player in the near future. The next category I wanted to talk about are monoclonal antibodies. So there are 3 monoclonal antibodies that have already received emergency use authorization from the FDA, and the most common and the most well-known is Regeneron's REGEN-COV. It was the monoclonal antibody that President Trump received when he had COVID-19. So this manufacturer has made a new monoclonal antibody called Evusheld, and it is a combination of 2 monoclonal antibodies that can be given through an intramuscular shot. So that's nice, because all the other monoclonal antibodies have to be given through an IV. So you have to go somewhere where they can put in an IV, and you have to sit there for hours while the infusion runs. And while we can use these drugs as outpatient, for outpatient treatments, it just makes it that much harder when it's an IV, versus if you can just give it in the muscle, it's a much quicker way to get people the medicine. So the previous monoclonal antibodies that were developed are short-acting, and they generally work to help people that have already contracted COVID-19 to not get more sick and or die from it. This new one, Evusheld, is developed to last longer, and it's specifically developed to help people not contract COVID-19 in the first place. So if you think about a monoclonal antibody, when somebody gets a vaccine, right, their immune system makes a response to that vaccine and makes antibodies. So monoclonal antibodies are exactly that. It's just that instead of your immune system making the antibody, it was made in a lab. So particularly helpful for people, for example, that have severe immunocompromised syndromes, where their body doesn't make a good antibody to a vaccine. The thought with Evusheld is that people that are immunocompromised can take this medicine. It can protect them, we're hoping, for as long as 6 months, so almost like a vaccine itself. And so far in studies, it's been shown to reduce the risk of contracting COVID-19 by 77%. So that's really, really good. Not quite as good as a vaccine in your own immune system making the antibody, but still it's pretty good, all things considered. The next 2 medicines I want to talk about are anti-inflammatory drugs. So We've been using steroids like dexamethasone, for example, for a long time to help combat COVID-19. I've talked about in previous webinars, a lot of the danger of COVID-19 is actually the reaction that your own immune system mounts. And so a lot of the trouble that people get into is a hyper-inflammatory state caused by our own immune system in response to the virus. So drugs like dexamethasone are used to try and block down that inflammatory response. So these two new players on the scene, baricitinib is a drug that blocks a chemical messenger involved in the inflammatory cascade. It's called IL-6. So it's a nib. Again, it works by blocking things. And then the second one on the list is teclistamab. That is one that's been around for a while. It also blocks IL-6. It's a monoclonal antibody, so it works just a little different than the kinase inhibitor above it, the nib. Both block that IL-6, both block down that inflammatory cascade, and they work similarly to the way that steroids do to try and, again, block down all that inflammation. With the second one, it's best used in conjunction with dexamethasone, but that's fine because, again, we've been using dexamethasone pretty widely since the start of the pandemic to try and combat all this inflammation. So I'm going to end there. I want everyone to remember this is a marathon. It's not a sprint. We've known that for a long time. We are going to get to endemic at some point. I think everyone in the meantime just really needs to be kind to themselves as we navigate this ever-changing pandemic together.
Dr. Gloria, thank you. I feel as if you were in part medical professor and in part you were our personal physician in the information that you shared and in the way that you shared it. So we now know about VER, we know about MAB, we know about NIB. And your last comment, probably the most important, be kind to ourselves, be kind to others. I also want to thank you because these presentations, and I think particularly this one, are your unpacking of the news, the headlines, and providing context for us. And as someone who received her undergraduate degree in journalism, I've been disappointed in how many journalists have been sensational rather than informational. And that doesn't help us as individuals receive, process, digest the news, and then make decisions for our own situation. So thank you very, very much. And now for our audience, we're going to turn to your questions. As a reminder, you can submit your questions by using that chat function on the right side of your screen. And please indicate which panelist or both you'd like to answer the questions. Any questions that we're not able to discuss on the webinar, we will try to address in a written Q&A in the coming weeks. So with that, we're going to start with questions that we received in advance of the webinar. And we've organized these in a couple of different categories. There are quite a few questions that came in that were about test and testing. Another set of questions came in about masks, about the Omicron variant, and then that longer term trajectory. So we're going to start with the questions about test first. And this goes to Dr. Gloria. What should you do if you take a home test and you test positive, but you don't feel bad? Should you call your doctor?
That is a really, really important question. So I'm going to reiterate that. I want everyone to listen up because this is so important. A rapid antigen test, which is what most people are using when they refer to home tests, is most accurate when you have symptoms. So it is possible to get a positive test result and not have COVID-19, particularly when you don't have symptoms. There can similarly be false negatives. So you may have symptoms because you have COVID-19 and your at-home test is going to say that you're negative. And we're seeing that particularly happening with Omicron. I'll just, again, take another little detour to say there have been some whisperings out there, I've seen it in the media, that Omicron actually is more concentrated in saliva than it is in your nasal passages. And again, that just goes back to the idea that it really likes certain tissues in the upper airway. So some are saying that saliva might actually be the better way to catch COVID-19 on an at-home test. So for me, this is my pro tip for you all. Take it or leave it. I can't give you any science to back it. I would use if I'm going to do an at-home rapid test, I would use the Q-tip first in my mouth to get a little bit of saliva, and then in your nasal passage so that you get a little sample from there too, and it just increases your chance of having a more accurate test. If you have symptoms and your rapid antigen test is positive, you can basically consider that that's a diagnosis of COVID-19. Always contact your primary care doctor if that's the case. If you have symptoms and your at-home test is negative, you should not assume you don't have COVID. You should approach that with caution. And I would recommend in that case, you also contact your primary care doctor. You're probably going to need a PCR test, which is still the gold standard, just as a backup to make sure that that test really is negative.
Thank you. And a follow-up question to that, just a reminder, when is the right time to take the at-home test?
Yeah, again, it's really best if you have symptoms. So waiting until that day that you've developed symptoms or even the day after, we're finding oftentimes with Omicron, the same day you develop symptoms, it's negative, and then the very next day it turns up positive. So in general, rapid tests were probably about 86% effective in catching COVID-19. That was with the previous variants. Based on my anecdotal experience, I would guess that they're probably closer to 70% accurate at picking up Omicron, so a little bit less so, 70 to 80% maybe. But again, making sure that you're waiting until you have symptoms, and then it's usually accurate for the first 4 to 5 days after symptoms start. After that, your rapid test is most likely going to be negative.
Are the new cases now being diagnosed considered the Omicron variant, or is it possible it's the original COVID-19 virus or the Delta variant?
We are still seeing Delta, to make a short answer of that question. Of all the tests that are getting genotyped, more than 90% right now are Omicron. So odds are that it's Omicron more than it is anything else. And some data points point to even higher than that, 98% are Omicron versus Delta. I will say, because we are still seeing Delta, there's a higher percentage when you look at, if instead of looking at all the positive tests that have been received by a particular lab, if you look at all the people that are in the hospital, you'll see a little bit more Delta there, just because Delta is more likely to put people in the hospital. But
okay, one more on test. How soon after exposure do symptoms appear? If there are no symptoms, how soon and how long can you transmit the virus?
So again, I kind of touched on this at the beginning with Omicron in particular, which we're seeing that the average time between when you get exposed and when you develop symptoms is 3 days. So generally you're considered contagious the day before you start having symptoms, all the way until about 5 days after that day that your symptoms started. So if you don't have symptoms, you can kind of use that timeline to guess if you know you had a real exposure. You would expect you'd be contagious about 3 days after that real exposure, if you're one of those asymptomatic cases.
Okay. There was a question which came in, does Goodwin House provide rapid test or PCR test? And what we'll do is, if you're a Goodwin House at Home member, we can make sure that Beth Robinson, our Director of Member Services, and her team provide you with information about the test. We will be providing the rapid test for members. Beth has been leading that effort. If you're a Goodwin House resident of one of our 2 communities, please reach out to the Executive Director. If you're a Priority Club member, we have not yet extended, I don't know that we will, giving away tests to Priority Club members or administering tests for Priority Club members. I will say that it is a very significant undertaking to test. Basically, anyone that tests has to be put in a very protective suit, and there is a lot of administrative work that is done because we have to document all the tests, all the individuals that are being tested. It is a very complex system. So just a little bit of background. It's not so easy as just do the swab, let me know what the results are. I'm going to shift to mask. There are a number of questions that are coming in live. I want you to know we're getting those. We'll incorporate those into each of the categories. So with mask, what mask should we be wearing right now? And is there a reasonable substitute for N95, which I can breathe in?
Yeah, I can testify to that for sure. So N95s are the best mask in the sense that they filter the most amount of viral particle. But the thing with the N95s is that they need to be fit tested. So generally when a healthcare professional wears an N95, we've gone through a process where we put a hood over our head and we have the mask on and they spray this really noxious spray inside. Imagine, it's not pepper spray, but imagine something equally offensive. And then we are asked to do all kinds of things, bend over, jump upside down, say the alphabet, sing a song. And the whole time we're making sure we can't taste that very bitter chemical that they've sprayed inside the hood with us. So that's fit testing. So that is the case in which an N95 really works the way that it's designed, because otherwise, if you haven't been fit tested, your mask could be leaking around the edges. And then it really diminishes the effectiveness of it if there's air getting in and out along the side of the mask in the first place. So if you're finding that an N95 is uncomfortable, I think that's perfectly fine. I think cloth masks at this point probably aren't enough because Omicron is so highly contagious. But if you could find a surgical mask that fits well, I think it's a happy medium where you can breathe and you're also giving yourself some protection.
Thank you. We're going to shift to boosters and vaccines. This is a question that came in live. I've been told by medical personnel that the booster is exactly the same as the vaccine in terms of the initial vaccine shots. If Omicron is so different, should the third and fourth booster vaccines also be modified to address the difference of the Omicron variant?
There's always been talk about changing the components of the vaccine, and because it has held up so well to the previous variants, that hasn't needed to happen. Now with Omicron, there have been some serious conversations with the vaccine manufacturers about changing the components. The problem is that it takes at least 6 weeks for them to recalibrate everything and remanufacture all the vaccines, and then they have to roll it out. And Omicron hit so fast that there just wasn't time to be able to do that. So I think it would have been nice to be able to change the component of a booster vaccine for Omicron, but it may be a moot point by the time we can actually get it done. But it is something that they are actively looking at right now.
I'm going to add on to that and just say that if Omicron emerged on the scene as quickly as it did, is it possible that the booster science will address Omicron and another variant could come in and the booster is looking in the rear view mirror one virus behind or one variant behind?
Yeah, exactly. I mean, that's always the point, is that we're always going to be looking in the rearview mirror. So
any other input that you provide on boosters, vaccines based on the topic today in Omicron? If someone has only received and they're fully vaxxed, should they go ahead and get the booster that's available now, as an example?
yeah, I'm seeing, again, Omicron has happened so fast. We just haven't had time to really collect good scientific data on how well the boosters are holding up. I'm seeing in just practical experience that people that are boosted generally have more mild cases than people that are just vaccinated, that just got the first 2 in the series. But what's really important is just being vaccinated. So just being vaccinated may be the difference between saving your life, and being boosted is probably more likely going to be the difference between I was mildly sick for a couple of days versus I felt pretty cruddy, but I didn't have to go to the hospital. Does that make sense, Lindsay?
Yes, that does make sense. So then a follow-up question, which has just come in, is it true that at some point all of us are going to be infected with COVID or some variant of COVID, most likely?
Yeah, I think so. Think about the flu. I mean, how many of us have never had the flu? I don't know. I couldn't raise my hand.
So what's to come? This is this next category as we look forward. If variants are to be the new normal, how do we prepare going forward? Do we assume life with a mask when we're out in public? What are other precautions or actions that we should anticipate also become part of our new normal?
So I'm gonna go back to comparing this to the flu again, just in the sense that I think the new normal is going to look very much like the flu does, where we see these seasonal upticks in cases. You know, again, maybe we get a vaccine every year in the fall, maybe we end up having to get it twice a year. But that is going to be the best way that we protect ourselves, just like it is with the flu. For me personally, as far as mask wearing and the decisions I make about the risks that I'm willing to take, it just really depends on the community transmission level and what's going on. And it depends on your personal comfort level. That's another thing. I think a lot of us, are probably more comfortable going outdoors right now without a mask. For me, particularly if I'm indoors, I'm definitely wearing a mask at this point. But as time goes on again and the cases drop, that'll change for me, and I'll feel probably more comfortable not wearing a mask outside at least, and then maybe at some point inside. I don't remember now with all of I think it was before Delta variant. I myself, I'm actually pretty conservative. I got to a place where I was comfortable eating inside restaurants without a mask, and I think that's where we'll get to at some point in our new normal, hopefully.
Question just came in. I think it's worth answering. Do influenza antivirals like Tamiflu work against COVID or Omicron? And do you see the over-the-counter products in terms of medicines morphing to that capacity?
That's a really good question. They did look at Tamiflu. That was one of the first antiviral drugs that they looked at. There's also a handful of antiviral drugs that are used to treat other viruses like Ebola and HIV that they looked at to see if it was effective toward COVID. And actually ritonavir is used to treat HIV. That's one of the medicines in Paxlovid, the new antiviral that's a combination drug. So they're looking, it's easier, of course, to go back to an antiviral drug that already exists and see, does that work against COVID, than it is to invent a whole new one and have to start from scratch with all the studies about what's the dose and is it safe and what are the side effects and all of that sort of thing. So they have definitely been looking at that all along. I think, unfortunately, it's looked like the Tamiflus and all the others are just not as effective against COVID-19.
One last question, and then we'll have just a few wrap-up slides. What do we know, or what might we project about the long-haul outcomes, ongoing physical, other impacts of the Omicron variant?
That is definitely a big concern in the medical community, because sometimes people that have been infected with the Delta variant, for example, that never had symptoms are developing this long haul syndrome, even though they never had symptoms of the initial infection. So we are all wondering if that's going to be the case in Omicron and what that's going to look like. But honestly, it is just too soon. Again, Omicron came on the scene so quickly, and we just don't have enough time yet to develop that data to see.
It will be very helpful to see what difference there has been in those that were vaccinated, with any longer term impact of Delta and ultimately Omicron relative to those that were not vaccinated.
Yeah, exactly.
Dr. Gloria, you've unpacked the news. You've kind of sifted out the sensationalism to give us the information that we need. You've provided great context. And as always, you've brought the best of your head and the best of your heart to this presentation. I want to thank you for that. And to our audience, just a few quick follow-up slides that we have for you, which Katie will advance for us. One of the things that we want to do is invite you to attend any of our upcoming events for Goodwin House at Home. And you'll see that there are a few events featured on this slide. One coming up on February 10, and that's going to be at Maggiano's in Springfield, and then March 10 at the Army Navy Country Club in Arlington. And so we mask up for these events, we socially distance for these events, and we take all the precautions that Dr. Gloria and others have advised. You can also access many resources such as our brain health program, Stronger Memory, other webinars, other activities that you can engage in at the Goodwin House website. And that URL is goodwinhouse.org. Just spend some time surfing the Goodwin House website and you'll see lots of resources to keep you mentally, socially, physically, cognitively well and healthy. And we hope that you will continue to reach out to us for any information that we can provide. We are here to support, honor, and uplift the lives of older adults, and it is our pleasure to serve you and our pleasure to have had you with us this afternoon. Thank you all so much. This concludes our recording. Stay safe and be well.